All right. Hello and welcome. Thank you for taking the time to review this slide deck before the June 24th Universal Healthcare Workgroup meeting. My name is Liz Argent and I'm the Project Manager for Health Management Associates. We've been contracted by HCA to help guide the workgroup through its process to deliver a report to the legislature with recommendations about how to provide universal health coverage to Washingtonians. Today, I'm joined by three members of the team, including Nora Leibovitz and Janine Smith from HMA and Shane Mofford from Optimus. The goal of today's presentation is to help prepare our workgroup members for the interactive activities that we will have during our June 24th virtual meeting, since we've moved to Zoom because of the COVID-19 pandemic. We've decided to pre-record our presentations so that we can focus our time together on dialogue to answer outstanding questions. We anticipate that we will be taking this approach for much of the duration of our work together this year, so we appreciate any feedback you have about the process. In addition to this presentation, I just want to mention there's another pre-recorded presentation that's been put together by the Healthcare Authority and its sister state agencies about the impact of the COVID-19 pandemic on Washington's health coverage landscape. Please be sure to review this presentation as well before the June 24th meeting. At the end of our presentation, we'll instruct you on how to submit your questions about this presentation before we meet on June 24th so that you can come ready with the knowledge you need to interact with one another. To just review, our June meeting will include time to discuss the three straw models that we're going to hear about today, talk about our process, and hear public comment. So I just want to provide a little context for everybody about how we got to where we are today with the three straw models that we're going to be talking about. So just to let you all know and remind you, the three straw models that we're going to be talking about today have been built on the discussions that we've had at prior workgroup meetings, including our work to define what universal healthcare means to everyone, an exploration of the root causes of why we have these problems in our healthcare system, a high-level review of international and national universal healthcare models and their key components, along with, and most importantly, the input from workgroup members throughout the process. In addition to this, we developed assessment criteria and established common language for our models. And now we've used a survey, which we're going to hear about today as well, to narrow to these three straw models that I keep referencing that address the identified priorities that this work group has identified in our work together. At our June meeting, we'll be taking these three straw models and digging in and answering the important outstanding questions that are necessary for our actuaries to be able to prepare dynamic models that we will spend time together at future meetings talking about. At our June meeting in particular, we'll be doing a virtual breakout session where each workgroup member gets to go through a review of each model and discuss these key questions. And then we'll be coming back together at the end of our meeting and sharing what we've learned. And then what happens after the June meeting? As I mentioned, our actuaries will then be taking these three straw models and doing some financial and actuarial analysis and create some dynamic models. Our work groups, future work group meetings, we will be spending time using our evaluation criteria and understanding what that means for each of these models and where they fall according to what our group has said matters the most to them. And then following that, we'll be developing our recommendations together, identifying outstanding issues that have not been addressed but still need attention. If possible, we'll be developing solutions. And finally, we'll be identifying near-term transition and other strategies to move forward on universal health care. And all of this will be compiled and put together in our final report that we will be delivering to the legislature later this year. So that's just a quick high-level summary of where we've been, what we're going to be doing at our June meeting, and what we'll be doing after the June meeting. So hopefully you all are grounded in kind of where we're at in the process. So with that, I'm going to turn it over to my colleagues Janine, Smith and Nora Leibowitz, who are going to talk about what we heard in the recent survey that you all completed.
Hi, this is Nora Leibowitz from HMA. I'm going to give you a little overview about the survey process, and then Janine is going to dig into what we found in the survey. So I wanted to tell you a little bit about the survey. The survey was really intended to help build the models that optimists will be assessing. And this is important because it's really not intended as a proposal that the work group is going to put forward to the legislature, but as the concepts that the work group will really dig in and assess once they see the findings and as Liz mentioned, utilize the other assessment criteria to think about each of those models. So the questions were developed and framed based on several things, including the conversations that we all have had at each of the work groups, as well as the components of international models and U.S. universal healthcare models that we discussed at the February meeting. The survey was initially sent out in early March, and the idea was to inform the development of the model. As you all know, due to COVID-19 and other factors, there was initially limited response, and with the cancellation of the April work group, we extended the completion deadline. When we closed the survey, the final response rate was about 60% of work group members. Highlights of the results are going to be summarized by Janine to help inform the June work group meeting discussions, and they're really not intended as a vote or a decision about models that we're settling on. So I'm going to quickly just share with you the types of questions that were included in the survey, starting with the who, and that is a couple of things. It includes whether who should be included in terms of decisions made based on citizenship and legal status in the country, as well as inclusion of residents based on their coverage type. The what is questions about the healthcare coverage benefits that would be included, so essential health benefits and other benefits as well. We asked questions about the participant cost share, which was about whether and on what basis people should be paying into the system. We asked about the use of federal funding for the program, including current federal programs and dollars associated with programs such as Medicaid and Medicare. And then we tried to get a sense of respondents' priorities by asking about a variety of issues that should be taken into account in developing a final response.
So the who should the model serve revealed that most of the respondents to the survey wanted models that covered all Washington residents, regardless of immigration status. There was also a question regarding inclusion of the state level coverage mandate, and the majority of those who responded suggested there should be a state level coverage mandate, but with some exceptions. Next slide. The responses were kind of mixed on whether the model should cover all residents regardless of their current source of coverage, so for those who are already insured. About 30% or so of those who responded wanted the program to only include people without current coverage source. But amongst those who responded that there should be some replacement of some of the current sources of coverage, the majority wanted to replace coverage purchased in the exchange, and many also wanted to replace Medicaid and employer-based coverage. A few wanted to replace Union Trust, Taft-Hartley insurance, which is often made through the unions, or Medicare. Next slide. When we get to what the coverage or services should be that are included in the model, there was a lot of support for the Washington State Essential Health Benefits Package. There was also a lot of interest in adult vision and adult dental, which is not necessarily included in most of those types of essential health benefits package offered on the exchange. And Medicaid required benefits above, meaning that they're richer or more robust than what is currently in the state essential health benefits package. There was some interest in coverage for alternative medicine services such as chiropractic, acupuncture, etc. There was also some that voiced an interest in including long-term care and services to support social determinants of health. Next slide. When moving to cost sharing, this being more what would the enrollees in the new model contribute, majority of the responses suggested that models should assume that enrollees pay a monthly premium, but that premium be based on a household income on a sliding scale to make it affordable. Respondents did express some mixed opinions on whether the model should include other cost sharing, such as co-payments or deductibles that are commonly seen in healthcare plans. A few respondents wanted the amounts of the co-pays and deductibles to also be income-based. Next slide. And then the last question was what type of priorities should be considered as the model thinks about its design and as it thinks about how it would be implemented. And the majority ranked affordability as number 1 or else number 2 in their ranking of priorities that were listed. Access came in most consistently at number 2, and equity was ranked by most at number 3. There was another option to write in some additional something else, and that was usually ranked number 4. Next slide. And of that something else, there were sort of some additional key themes. Quality of care or quality showed up and was noted by at least 3 of the respondents. Providers, the focus on what the role of providers are and provider control, provider payment reform, and easing provider burdens, simplifying administrative aspects also showed up consistently in this free open write-in section. And sustainability was also noted by 2 members. The other comments were to have as complete a coverage as possible. Outcomes was noted to be important. Getting buy-in or the ability to market this idea and to the people of Washington State. A comment was made of including everyone will make it possible to control costs. Cost effective popped up. Price transparency and ease of use was a priority, and public accountability. Next slide. So then
I'm gonna
go. I'll turn it over to Nora.
Okay, and I'm gonna do quickly. I'm gonna talk about based on the combination of the feedback that we've gotten from the work group discussions at the different meetings, as well as responses to the surveys, the 3 straw approaches that we put together for Optimus to do its evaluation, and for us first to talk about and refine at the June meeting. So the first one is universal coverage that is administered by the state, and the population to be covered is all state residents. And it's notable that in this universal coverage scenario that the state is very active in terms of the state defines the benefit package, what are the covered services, the state is determining the delivery system rules, and that includes things like the use of value-based payment and prioritization of primary care, that kind of thing. And that the state directly contracts with providers, setting the rules for the providers and having the actual interaction with them. So this universal coverage, state administered, has no participation by health insurance carriers. Just want to note a variant, which we're calling Universal 1.5. The only distinction in the variant is that that residents who currently are covered by some or all federally funded coverage, including Medicaid, Medicare, people who are federal employees and have coverage through their employers, veterans coverage, that those folks would not participate under the variant, but everyone else in the state, whether they had coverage on their own through an employer or no coverage, that everyone else would be covered. So for option B, which is again a universal coverage option, but this time the administration is delegated, and so I'm going to talk about what that means. Again, universal coverage, so participation by all state residents. The state again defines the benefit package and sets the rules for how services are organized and how payment works, et cetera. But this time, health insurance carriers would contract with the state to provide coverage. And those carriers, as they do now, would contract with providers to participate in the program. Again, the variant this time, Universal 2.5, again, would be a program for all state residents except for folks who have federally funded coverage. For our third option, option C, we're calling it the fill in the gaps. And this would be coverage for people who don't currently have access to coverage, who don't have coverage. And so participation would be for state residents who don't have federal coverage, don't have employer-sponsored coverage right now. And this could include or exclude, depending on the program, folks who are currently enrolled in exchange coverage and getting premium tax credits through that program. So that'll be an option for discussion. Again, the state is defining the benefit package, and this is really, it may seem familiar to folks, sort of the cascade care idea, in that the state is setting the rules for participation, saying that certain things need to happen, use of value-based payment, et cetera. But in this case, broader than cascade care, anyone who is not able to get coverage through an employer or federal coverage could enroll. And again, as Cascade Care is organized, carriers apply to participate, and if they meet the requirements of the program, then they can offer a Cascade Care package and they contract with providers. A potential variant for this one is to offer additional state subsidies. Right now, folks who go to the exchange and are financially eligible can get premium subsidies in terms of advanced premium tax credits. This would add to that a state subsidy program, and we're aware that currently the Cascade Care Work Group has been discussing a study that's been done on state subsidies and reviewing the subsidy approach for participants with income up to 500% of the federal poverty level. And as information from that group is available, we'll incorporate it into our work group analysis and discussions going forward.
Okay, we're going to now turn it over to Shane, who's going to dig deeper onto these models and talk about some of the impacts that we can see at a high level.
Great, thank you very much. So if you could go to the next slide, please. So the purpose of this section is to introduce high-level concepts that will be important for work group members to consider going forward. Statute requires recommendations in the final report that account for a quote-unquote just transition for all stakeholders. This requires thinking about how different models impact different stakeholders. And while not a comprehensive set of considerations, the examples that follow help illustrate some of the types of impacts the work group will need to consider and address as part of the final report. So again, we'll be looking at the three models that you just heard about. The three models include universal coverage that's state administered with all Washington residents. The state is responsible for all payer functions. The provider network remains private and the state directly contracts with the provider network. The universal coverage with delegated administration is different in that the state contracts with managed care plans, and the managed care plans then fulfill many of the payer functions, including contracting with the provider network. And then lastly, the fill in the gaps model, which provides coverage for people without coverage. Subsidized access to care for those that do not have access to affordable coverage. And for the purposes of the examples that follow, conceptualize something akin to the cascade care model. And the work group will need to help define the target population for this model and think about what affordability means. So to facilitate the discussion, we'll be focusing on 4 areas: access, provider compensation, economic impact, and efficiency. Starting with access, we know that there are significant challenges in the current system. For example, reimbursement-driven limitations negatively impact access. This phenomenon is driven by the different levels of provider compensation from each payer. Typically, Medicaid is the lowest reimbursing payer, followed by Medicare, and commercial takes the lead and pays the most. Practices may have to limit the number of Medicaid and uninsured that they add to their panel to ensure that their businesses remain solvent. Additionally, with premium costs so high, some individuals that do not qualify for public coverage cannot afford the premiums and simply go without any coverage, and they can have a hard time finding access to care when they really need it. And then lastly, both in the case of the uninsured and those with high cost sharing, access to care can be self-limited to avoid financial disaster. So in what ways can each model impact access? Let's first look at the reimbursement-driven limitations. Under the state-administered universal coverage option, the variation in payment levels by payer source goes away. With it, any panel restrictions for certain payer sources that exist in the current system also go away. Depending on how prescriptive the state is under the delegated administration model, much of this effect is also mitigated there as well. More than likely, the plans that bear risk under this model would negotiate provider rates within a much narrower range than the current range that we see between Medicaid and commercial. And then lastly, the close the gap model adds another payer to the current mix and does little to mitigate the reimbursement-driven access issues. The one exception would be that for anyone that's currently uninsured that gains access through that mechanism in the future. For both the unaffordable premium and cost sharing issues that impact access to care, the universal coverage models should remediate these impacts. Presumably, these models would be designed with premium and cost sharing affordability in mind. Under the close the gap model, premium affordability and cost sharing is likely addressed for those that sign up for the plan, but it won't address those with other types of coverage. Looking at the impacts on a different topic, provider compensation, there are issues here as well. We have already discussed that there's a great degree of variation in provider compensation across payer types. A provider's average reimbursement for a service varies based on what type of insurance their panel carries. The reimbursement level isn't the only source of variation across payers. The billing policies, payment models, and covered benefits may vary as well. Navigating the different requirements of each payer adds a tremendous amount of administrative burden for providers. Resources are spent navigating a convoluted insurance system instead of spending resources on providing care. Additionally, the multitude of payers fragments purchasing power in the state, which makes movement towards value-based purchasing a challenge. And in some cases, it actually drives up reimbursement rates. How does each model impact provider payments and payment policy? The state-administered model eliminates cross-payer pricing variation, with the exception of any federal programs that might be excluded under the model variations. The delegated model could potentially have variable rates, but the amount of pricing variation would be drastically reduced due to far fewer plans participating in the market at that point. The close the gap model creates another payer and does nothing to reduce payment variation across payers. In terms of average compensation and its dependency on payer mix, the average compensation for services is no longer payer mix dependent under the state administered model. The variation is reduced under the delegated model, and the variation persists under the close the gap model. This raises an important consideration for the work group. How providers are impacted by the implementation of a new model will largely depend on their payer mix today. For the sake of discussion, assume that the level of reimbursement in the universal coverage model will be higher than Medicaid and lower than commercial. This means that providers with a high percentage of commercial members on their panel will see decreases in total compensation under the universal coverage models. Providers with a high percentage of Medicaid members would see an increase in total compensation under the universal coverage models. Given the requirement for a just transition, what type of policies would be appropriate to mitigate any unintended consequences from the elimination of compensation variation due to payer mix? Looking at the variation in payment policies, consolidation under the state-administered plan would result in wide-scale standardization of billing policies, value-based purchasing strategies, and ultimately potential efficiencies for practices and the delivery system as a whole. This effect is true under the delegated model, but some variation may persist depending on how prescriptive the state is with the delegated plans. Under the close the gap model, there is an additional plan added to the mix, and none of the variation in policies is reduced. How about economic dynamics today? The economic dynamics in the current markets are complex. The insurance industry is fragmented with a multitude of payers. These payers employ large numbers of employees with a variety of skill sets and act as economic drivers in of themselves. The health insurance market and employment market are intrinsically linked today. For many, employment is the source of insurance coverage. This means that changes to how individuals obtain insurance coverage can impact their employment decisions. And while the fragmentation that occurs by having so many payers drives inefficiencies, the presence of competition can have a positive impact. Payers innovate to drive costs down to be able to offer competitive premiums for coverage. How do the different models impact economic dynamics? Transition to the state-administered model would eliminate the fragmented coverage system. This would likely result in a significant amount of job loss for those that participate in or support the insurance industry. Some staffing would likely migrate into state employment, but only a portion. Under the delegated administration model, there would still be consolidation, but part of the current fragmented system would be kept intact. Rather than plans offering coverage to employers on the exchange and through other means, plans would bid for contracts with the state to offer services to subsets of members enrolled in the universal coverage. In essence, this model doesn't achieve the same levels of consolidation, but also doesn't result in the level of job loss from the insurance industry and those that support it that you would see in a state-administered model. There is no consolidation of the fragmented market in the close the gap model. It persists. The direct linkages between the employment market and the insurance market are eliminated under the universal coverage models. Indirect effects such as taxation still need to be considered. The linkage is retained under the close the gap model. And lastly, competition is eliminated in the state administered model. There would be no competing health plans. Under the delegated administration model, there would still be competition, but it's limited to competition for covered lives participating in Washington's universal coverage model. The close of the gap model retains current market competition if the plan is designed to offer coverage for those that currently don't have it. If the close the gap model competes with commercial plans, very different economic considerations come into play. And efficiency. Lastly, looking at efficiency in the current system, the fragmented market has consequences. Delivery system reform efforts are diluted due to the fragmented strategies. The same is true for analytics and fraud, waste, and abuse detection. The fragmentation results in each payer seeing a limited part of the broader healthcare delivery system. Further, having the administrative and technical infrastructure to support a multitude of payers is inefficient. Economies of scale and purchasing power are diminished. How does efficiency change under the different models? When there is a single payer, as with the state-administered model, delivery system reform and value-based purchasing strategies are consolidated. The likelihood of success is higher when providers can focus on the requirements of a single payer. Under the delegated administration model, how much consolidation of strategy occurs will depend on how prescriptive the state is. For example, the state could require the plans to use a consistent set of performance metrics and value-based purchasing arrangements. The close the gap model does not contribute to the consolidating of delivery system and payment reform strategies. In terms of analytics and data aggregation, the state would have full access to the comprehensive statewide utilization data under both universal coverage models, and would be in a position to drive policy based on this broader data set. Under the close the gap model, the state could still access the data through the all payer claims database, but it isn't in a position to make it actionable for all covered lives in Washington. And lastly, duplicative infrastructure is drastically reduced under the state administered model. It is somewhat reduced under the delegated administration model, and under the close the gap model, duplicative infrastructure persists. So some key considerations. Statute requires the committee to recommend strategies that provide for a just transition for all stakeholders. It is important to think about the policies from a variety of perspectives. The examples provided today are to help the work group think about the implications of changing the insurance coverage model from multiple different perspectives. Policies that make sense at the aggregate level can negatively impact individuals, and some policies will simultaneously create benefit for one group while creating hardship for others. Movement to a single payer system and the variable impact based on panel payer mix is a really good example. In the breakout groups, try to think about each issue from a variety of stakeholder perspectives. The work group is ultimately responsible for proposing solutions that address different stakeholder needs that come with significant coverage reform.
Thank you so much, Shane and Nora and Janine. That was a wonderful presentation. Just a reminder for our work group members, these are straw options that really are intended to kick off our discussions at the June meeting, which will happen on June 24th. And these models are really about offering frameworks so that our actuaries can do some financial analysis and modeling. And they'll be refining these based on the components that we discussed during our meeting on June 24th, because as you should recall, they're only able to model a few options, and they'll be bringing those models to future meetings. So please take some time to consider the considerations that Shane outlined during his overview of the three models. At June, we'll be sharing the results of the breakout discussions at the end of our meeting, and then we'll be summarizing that and sharing it with everyone, and it will be factored into our model refinement. And then we'll be coming together later in the summer and digging into each of those more in a deeper fashion. So I just again want to thank our presenters today, and thank you for spending your time doing your homework so that you can be prepared to dialogue on June 24th. We're asking if you have questions to please submit them by 5 p.m. on June 19th. That's the Friday before our work group meeting. We'll be reviewing the questions as we get them on a rolling basis and providing answers to the work group. So please send those along. And finally, one quick reminder, if you haven't registered for our meeting, please do so. It will allow us to make sure that our virtual meeting runs smoothly. And just again, here's the email for you to submit your questions about this presentation or the COVID-19 briefing presentation that you'll be getting from HCA and the sister state agencies. So again, thanks for your time today and stay safe. Stop. How do I do this?